Sure. Well, thank you for having me. Um, for the starters, the condition of calciphylaxis is a serious complication that patients with end-stage kidney disease typically encounter. And even though a lot is still unknown about calciphylaxis, what we know so far is patients who suffer from it develop painful skin lesions, typically in areas such as the lower abdomen or thighs or buttocks. And these skin lesions are not only quite painful, but have a distinct propensity to get infected. So many of these patients land up in the hospital for conditions like pain control or managing the infections. Now, one may be wondering, why is this skin lesion developing in somebody who has end-stage kidney disease? And that's where, especially until recently, a lot was unknown. But now what we know is, first of all, the lesions develop because the blood flow to the skin tissue is cut off. And the main reason we think that blood flow is cut off is because the small blood vessels, such as arterioles and small arteries in the skin tissue, are developing calcium buildup in their wall. As a result of that, the walls are quite calcified and they are not able to then carry the blood as smoothly as possible. As a result of that, of course, then the blood doesn't get to the skin and the skin breaks down and patients have lots of pain. And, although it's a rare disease, typically I would say one follows around 1,000 dialysis patients for 1 year in the setting like in the United States, maybe 3 or 4 of those patients will develop calciphylaxis. Although I have been speaking mostly for patients with dialysis, the condition is not restricted to that population. Very occasionally, we may see calciphylaxis even in patients who have either milder degree of kidney disease for which they don't require dialysis, or even in some patients without any kidney disease. So it's a serious disease. Unfortunately, in addition to the morbidity, has 1 year mortality that approaches around 50%. And again, quite unfortunately, despite the disease being around for over 5-6 decades, we do not have any approved therapy to offer to these patients. And that has been one of the main, I would say, missions of my laboratory work. Yeah, no, that's a fantastic question. Of course, a clinician is, literally grasping, the straws when it comes to treating a patient with calciphylaxis. We, of course, focus on managing pain, but important to note that even some of the strongest pain medications do not offer pain relief to these patients, and many a times the adverse effects of those pain medications take over and limit the use of those medications, such as opioids in particular. We try to, of course, manage the wounds with different types of wound dressings or sometimes with surgical procedures like debridement or amputation. We try to treat infection if it is present with very strong antibiotics, but again, frequently that is not sufficient, and these patients do get what we call septic as a result of these wounds. There are some, I would say, off-label pharmacotherapies that have been described. One of them is known as sodium thiosulfate, which is typically given intravenously. There are some other, I would say, also off-label treatments such as bisphosphonates. There are some sporadic reports of use of treatments like vitamin K. But again, none of them have been rigorously tested and do not have consistent effectiveness. And some of them are actually quite notable for their tolerability issues or lack of tolerability, rather. We also focus on eliminating the risk factors that we currently understand that predispose patients to calciphylaxis. So medications like warfarin, which is a vitamin K antagonist, typically gets stopped for this patient. But again, as you can hear from what I'm saying, a lot of it is, I would say, non-specific, non-targeted treatments, primarily to alleviate the suffering these patients are undergoing. And many times, despite these best attempts, these patients do not do well and are frequently then we are inviting more like a hospice care for these patients and withdrawal of dialysis in many instances. Yeah, that's very interesting. So This is, I would say, relatively new information. So one of the, I would say, aims that my, again, research team is working on is trying to understand, what is going on at the molecular level that, results in predisposing some patients to develop calciphylaxis. And one of the main theories that we are working on there are like these inhibitors of calcification in the body. One of them is PPI, or inorganic pyrophosphate. And the postulate that we are testing is it the deficiency of some of these inhibitors that is predisposing these patients to develop the complication of calciphylaxis? And so I would say it's only in the last year or so that we have shown in some early studies that patients with low pyrophosphate levels have um, um, a higher propensity to develop the complication of calciphylaxis. And these are PPI levels that we have measured in circulation, so using the patient's plasma samples. And then, in fact, this association between the low PPI and the development of calciphylaxis holds true not just for patients who have end-stage kidney disease that requires dialysis, but also for other individuals who are not on dialysis. So that's been a fascinating, I would say, observation. And more importantly, we also have some, again, recent data that supports that among patients with calciphylaxis, those who, let's say, die within the first 6 weeks of their diagnosis, or within 6 weeks of entry into our study, those patients who die have much lower level of pyrophosphate at the time of initial entry into the study compared to those patients who remain alive. So we have this, not just the pyrophosphate as a marker for development of calciphylaxis, but also as a risk predictor for outcome in patients who have developed calciphylaxis. We also have some correlation between, as the pyrophosphate level goes down, the number of skin lesions that some of these patients have kind of increases in a stepwise fashion. So that has been also quite interesting to note. And of course, then that provides the foundation to then potentially test the next theory, which is can we actually correct pyrophosphate and maybe either improve calciphylaxis or prevent calciphylaxis and broadly like calcifications in our patients. Sure. So Inozyme is the company that has developed INZ-701, which is essentially an enzyme known as ENPP1. It's attached to a fusion protein. So ENPP1 is a critical enzyme that is needed to make inorganic pyrophosphate in the body. So think about it as in patients who have low pyrophosphate, can we actually give them this enzyme to so that they can, have more production or more availability of this inorganic pyrophosphate. The medication, or the drug has initially been already tried in some clinical trials for patients who have some genetic abnormalities that are responsible for low levels of pyrophosphate. And some of these are conditions that are typically seen in young kids. And these kids are, developing calcifications in different body organs, like, their large blood vessels, but also maybe around their joints and other body parts. And the drug is already in clinical trials and actually has advanced nicely for those indications. What is new for us is, and what was presented at the Kidney Week meeting just this past week in San Diego, was the demonstration that in individuals who have end-stage kidney disease and are dependent on dialysis and have low inorganic pyrophosphate at baseline, subcute injection of INZ-701 administered once a week for a few weeks can actually completely normalize the circulating levels of inorganic pyrophosphate. So that has been, a very, very, I would say, important kind of a proof of concept data for us to show that now, although none of these patients in this initial trial had calciphylaxis, at least, we know that, in a population such as dialysis population, which is the main, I would say, cohort that is high risk to develop calciphylaxis, we can change or increase the level of this inorganic pyrophosphate with INZ-701. So this is a very exciting initial step. And then at least again, I feel as an investigator, these are the kind of, as the science goes through these different steps, we are getting, one step at a time closer to really potentially then testing this therapy in patients who have calciphylaxis. Yeah, no, of course, very important follow-up questions. So I would also mention that this phase 1 study that Inozyme just recently wrapped up, they also there was no concern for kind of safety or tolerability of this drug in this dialysis population. So this is also, I think, an important observation, especially considering this is the first time that this drug was administered in a cohort of dialysis-dependent patients. Also, somewhat surprisingly, and I'm still actually trying to understand the effect on some of the other mineral bone dynamics that were observed. So, for example, I think there was like approximately around 12% reduction in serum phosphate with INZ-701 treatment. There was also, I think, a little bit over 20% reduction in a dynamic known as FGF23, the fibroblast growth factor 23. Now, by design, at least I couldn't at least at this point, I cannot explain these results. They're of course going in the direction that is likely going to be favorable. Meaning, in dialysis patients, we of course always try to reduce the serum phosphate if it is elevated, because that is another risk factor for developing calcification, and FGF23 also high levels have been linked with worse outcomes in dialysis patients. But having said that, this is a small study. There was no control group, and sometimes these effects can be just the fact that patients get into the trial, so they may change their behavior in terms of their diet or something else, and that may be responsible for some changes that we're seeing with phosphate, for example. But the next steps, is where I think the really we are kind of looking forward to is to work, continue our collaborative work with the Inozyme, and then design a potential clinical trial that then brings this study drug INZ-701 to calciphylaxis patients. The timeline, I would say at this point, I would probably defer to Inozyme Pharma in terms of the exact details, but I'm hoping it comes as soon as possible, just considering the high unmet need that these patients suffer from.